Good morning, everyone. Before we begin, may I please remind you to silence your cell phones. Restrooms are outside. If you have to take a call or step out, please feel free to do so with the minimal disruption. Thank you again for joining us for one of our events that we normally do each month, or we try to do each month. So we appreciate your being here. So good morning, everybody, and welcome. My name is Dawn Walker. I am Vice President of Communications and Marketing here at Downstate. And today I'm happy to welcome you to our AAPI presentation. In recognition of Asian American and Pacific Islander Heritage Month, I'm honored to open up today's discussion, Not Just a Demographic, Shaping Health Equity from Within. This event holds both professional and personal meaning for me. As a communicator, I think deeply about how identity, voice, and narrative shape the public's understanding of who belongs, who gets seen, and who gets heard, and who gets cared for. As someone who is committed to building inclusive spaces in healthcare, I know that we cannot do this work effectively unless we first acknowledge the complexities that exist. The term AAPI is often used as a single demographic label, but it encompasses a vast range of lived experiences among more than 50 ethnic groups and over 100 spoken languages. That richness is too often reduced or misrepresented. And in doing so, we miss the opportunity to address these communities' specific health challenges, cultural dynamics, and structural inequities. Today's panel is an invitation to look deeper, to listen more closely, and to understand how data, practice, policy, and storytelling must all evolve to reflect the true diversity of the AAPI experience. We're fortunate to be joined by a panel of scholars, clinicians, and public health leaders whose insights are grounded in professional and lived experiences. Guiding this conversation is someone who brings that same dual lens to the moderator role. Dr. Vikram Pagpatan is a nationally recognized occupational therapy educator, advocate, and academic leader whose work intersects with equity, technology, and culturally responsive practice. As a proud City University of New York alum and associate professor here at Downstate, he leads critical initiatives in admissions, assistive technology, and inclusive education. A first-generation South Asian American and past president of the Asian American Pacific Islander Occupational Therapy Association, Dr. Pagpatan brings a deeply personal and professional understanding of the nuanced experiences within the AAPI communities. His scholarship and community work center advancing accessibility for marginalized populations and empowering the next generation of healthcare professionals through meaningful engagement and representation. He is quite simply the ideal voice to lead this discussion today. I want to thank our panelists for giving us this time and their attention, and for their generosity and candor that they will no doubt bring to this conversation. But before we begin our discussion, I would like to invite someone else to the podium. Please join me in welcoming Jamie Greco, our Senior Vice President and Chief of Staff in the Office of the President. Jamie is a key strategic leader at Downstate, helping to drive initiatives that reflect our institutional values. He will bring greetings on behalf of President Riley. Jamie, thank you.
Thank you, Dawn. Good morning, everyone. My name is Jamie Greco. I'm Senior Vice President and Chief of Staff for the Office of the President. It's a pleasure to join you today, and I bring greetings on behalf of President Wayne J. Riley. President Riley sends his warmest regards and his deepest appreciation to all of today's panelists, organizers, and attendees. He's proud of SUNY Downstate. He's proud that SUNY Downstate continues to elevate conversations that reflect both the diversity of our institution and the equity we aspire to model in academic medicine. Today's discussion, Not Just a Demographic, Shaping Health Equity from Within, is exactly the kind of engagement President Riley envisions when we speak of Downstate's mission as a community-anchored institution. We're not only training the next generation of healthcare professionals, We're actively challenging outdated assumptions, advocating for data and policy that reflect real communities, and fostering leadership that is as culturally grounded as it is clinically excellent. As healthcare professionals, researchers, educators, and advocates, understanding how we communicate across vastly diverse communities is essential. It's not just about language, it's about listening deeply, recognizing nuance, and building trust. When we acknowledge the specific histories, values, and experiences of the people we serve, we create care environments that are not only more equitable, but more effective. This kind of cultural and linguistic fluency isn't a nice to have, it's foundational. It informs our research design, our clinical decisions, and our outreach strategies. It shapes how we train students, how we engage with policy, and how we build systems that truly work for everyone. And nowhere is it more important than here in Brooklyn, where our neighborhoods reflect the global majority. The AAPI community is not a monolith. And in this space, we affirm that complexity is not a challenge to overcome, it's a strength to embrace. On behalf of President Riley, I thank you for being here. Thank you for lending your voice, your story, and your vision to this powerful conversation. We're honored to have you today. Thank you.
It's an honor to welcome you to today's AAPI Heritage Month, not just demographic, shaping health equity from within. My name is Dr. Vikram Patton, and I am deeply humbled to serve as your moderator for this powerful but yet timely conversation. The title of today's panel is not just a phrase, it's a quiet resistance to how many of us have been categorized, misunderstood, or simply just erased. Demographic is a term we often encounter in data reports, checkboxes, or diversity statements. And while representation matters, being seen only as a demographic is not the entire story. Behind every stat are individuals, leaders, who have broken barriers, carry generations of hope, and committed their lives to reshaping the very systems that once excluded them. We gathered today to reclaim that narrative, to remind ourselves that we are not just numbers on an enrollment chart or data points on an equity report. We are educators, clinicians, researchers, policy shapers, and above all, we're advocates for justice. There is no better place to hold this conversation, by the way, than here at SUNY Downstate Health Sciences University. As Brooklyn's only academic medical center and a proud institution that serves one of the most culturally rich and medically underserved and misunderstood communities in the entire country. Downstate is more than a healthcare institution. It is a symbol of what it means to lead from within. For generations, it has trained a workforce that looks like us, speaks like us, and heals the community it serves. It has given voice to students who are often the first in their families to walk hospitals not as patients, but as providers. And it continues to stand as a beacon for inclusion, resilience, and especially this, community-grounded care. Today's panel is not only a celebration of resilience and brilliance of AAPI leaders who have navigated the intersection of culture, identity, and healthcare, it is also a call to action, a call to acknowledge that health disparities that persist, stigmas that silence, and the leadership gaps we must continue to bridge as stakeholders of the healthcare community. As you listen to our esteemed panelists, I invite you to reflect and to move beyond what is seen, but rather what is heard, from being included to being valued, from being labeled as diverse to being recognized as architects of transformation. I'm so excited for this conversation. Let it be intimate, let it be powerful. Lean into being uncomfortable, folks, because we're going to get into topics that really talk about not only Downstate's value, but also the value of being different and how that means and what that means to the consumers that we serve. So let's begin our conversation with the first panel, the first question, in regards to understanding the narratives. Our personal narratives shape who we are. To be a healthcare provider is to first understand who you are as a human being. So the first question, what inspired you to journey into healthcare or public health?
Good morning, almost afternoon, everyone. My name is Tina Kim. I am the Deputy Commissioner for the Office of Health Equity and Human Rights at the New York State Department of Health. So the Office of Health Equity and Human Rights was established in 2022. It's one of the newer offices, and a lot inspired me to get there. Starting from my personal journey, I grew up in an immigrant family. My parents were both full-time working and trying to pay the bills. And me, as the eldest daughter, the first English proficient family member, I was often charged at a very young age to help answer the phone calls from the telemarketers and pay the bills. And I think with that responsibility came the responsibility to then help them navigate the healthcare system. And I mean, it's already frustrating to navigate the healthcare system now. Imagine in the late 80s, early 90s, as like a young child, having to do that for your family. And out of that frustration birthed my desire to really help influence the public health and healthcare system. So like every other Asian child, I thought I should become a doctor. And I started down the pre-med path. And then I realized, wait, I want to think about treating people before they get sick, before they end up in the doctor's office. And so I learned about public health. I got into it. And my career started off building a healthcare program for uninsured and underinsured Angelenos in Los Angeles County. And that also birthed from my personal experience having to navigate, healthcare services for my family who didn't have employer-based coverage. We barely had enough to put foot on the table. And I was able to, inform my work experiences with my experience of navigating the healthcare system personally. And over time, that really helped me develop a competency in this intersection of public health and healthcare delivery systems. There's different language that is used when it comes to delivery and even public health. And so for me to translate between the two worlds to then figure out, like, how do we best serve people in that intersection of public health and healthcare, that's where I developed my career in, and that's where I continue to influence policy decisions to this day, and I'm very, very grateful.
That's powerful, Tina. I think your sentiments about navigating healthcare systems, especially with generational values, my mother, doctor or nothing, right? More or less, I'll say I'll take nothing and go from that perspective. But in many cases, it's shared values that often are connected in terms of communities. We don't recognize the values in terms of how they shape policies and how they shape consumer needs in many, many respects. So thank you for sharing that. That's very powerful. Jennifer?
Hi, everybody. My name is Dr. Jennifer Park, and I'm the director of the cornea service at SUNY Downstate. And I've been working at Downstate since 2019, and it's been a great time here. In terms of what inspired my journey into healthcare, since I was young, I was always interested in science, and my parents highly valued education. And, science continued to be an interest of mine as I grew up. And I think that the pivotal moment that, really pushed me to go into medicine was when I took a trip to Ghana after I graduated from college in 2009. And basically, I went to Ghana with an organization called Unite for Sight, which aims to deliver eye care to populations that can't access it. So we went to rural areas in Ghana, and we provided them with glaucoma treatment and also performed cataract surgeries and other types of eye surgeries. And seeing how much of an impact restoring someone's sight can make to one's livelihood and just whole quality of life was very impactful. And that's when I decided that I wanted to go into the field of ophthalmology.
Thank you, Jennifer. I think that's amazing as well in many respects. Your experiences in Ghana, do you think that they shaped the way that you looked at communities of need in general in terms of their perceptions of health, access to health, and even in many cases an entitlement to health?
Yes, that's a great question. I think that my experiences in Ghana definitely, have a parallel to the population that I treat right now in Brooklyn. I treat patients who are, predominantly from the Caribbean, many new immigrants who did not have a lot of healthcare access and who don't have a high level of healthcare literacy. And that was similar to the case in Ghana where patients were not able to get access to healthcare and didn't really understand why they weren't seeing well. So I think that, there are definitely a lot of similarities to the two populations.
Awesome. Thank you, Jennifer. Ranjita?
Hi, everyone. I'm Dr. Ranjita Raghavan. I am a assistant professor of emergency medicine, so I work in the emergency department here. And I got into medicine. I mean, I think I was interested in it because of maybe similar reasons to a lot of people are interested in it. But really starting out, my mom is a psychiatrist, and getting to see how much she loved her job and the impact it had on her patients really kind of inspired me to find something that I felt that I could get that same enjoyment from for my career, right? But once I got to medical school, I was really drawn to emergency medicine because I liked the idea of getting to really see lots of different people's stories. And it's just amazing how many different people you can meet and like how different everything is. And I went to Mount Sinai and Elmhurst for residency. I went to USC for med school, and then I did a global health and education fellowship at UCSF Fresno. And I just was interested in learning about as many different cultures as possible and seeing what our similarities were, and then also the differences. And there's all these unconscious biases that you don't even realize that you have, but it was really delving into those different stories and getting to work with these amazing people and see the patients they're treating in a lot of different communities that really interested me. And I'm lucky enough that at Downstate they're letting me kind of pursue some of these opportunities and help out with the residents as well to kind of have those experiences. So yeah.
Awesome. Thank you, Ranjita. Yeah, I think a lot of the experiences you just shared about generational values, we're also going to talk about generational trauma as well and how that informs not only what we do, but why we do it, especially here at SUNY Downstate. And going back to Jennifer as well, talking about correlations between communities, the West Indian and Afro-Caribbean communities, as well as the AAPI communities. Do they really have to be separated in terms of what we do as practice, what we do for research? There can be correlational variables that we can kind of better understand to better treat communities of care. Going back to Ranjita's experiences, being inspired by our own family members, being inspired by our own values, can that also foster a greater level of cultural competency, cultural humility moving forward in treating very complex needs and very complex communities? So yeah, I'm looking forward to this really powerful conversation. Going over to Robert, Dr. Wong.
Yes, thank you. My name is Bob Wong, and I'm a distinguished professor and chair of physiology pharmacology here. I was born in China, but moved to Hong Kong in after liberation, after the communists took over China. And I am here mainly and welcome the opportunity to share with you my experience as a naturalized citizen of America and the experience I have in that capacity and the kind of subjective feeling that I have, as well as roadblocks, as well as challenges, as well as excitement that I encounter in this country. And I think that with the forum here, eventually as we go into the program, I think that I like to know more of the participants of this forum, learn from them, as well as contribute to the richness of the composition of this forum, as well as the audience, and hopefully that you can find my conversation sincere and direct.
Thank you, Dr. Wong. I'm looking forward to really kind of dissecting the polarity as well. What does it mean to be Asian? What does it mean to be American? And what's the buffet, right? What's the Asian American truth in many respects? So yeah, thank you for that. And Subud?
Thank you for welcoming me to this and making me a participant in this symposium. I'm delighted to be here, and it's an honor, honestly. I was born in India, had a very difficult childhood in a family that had about 8 kids. I was eventually given away and had a lot of childhood trauma, but believe it or not, I initially learned my ABCDs and by listening to school kids, and there was a lot of deprivation as in my childhood. But then subsequently things changed for the better because India has a very good system of following up children that are given away and monitoring their well-being. To make a long story short, I was, so I had a yearning for education, and I always felt I was rescued in many parts of my journey through some divine intervention. I couldn't explain it, how I survived. But my real reason of going into science was my teachers, my mentors, I think. They really guided me and gave me an interest into chemistry, physics, zoology, and biology at the undergraduate level. And I think my real moment came when one of my biology professors asked me to show me from literally nothing, mount on a slide ciliated epithelium in my high school. I had no idea where in goddamn do I find this? And I finally had to do some search, and I found out it lies in the nasopharynx of a toad. How do I get a toad? Which is a challenge. I finally found through my lab people how to find that and get me the toad, and I had to find ways to scrape it under anesthesia and mount it. And for the first time in my life, I saw life under a microscope. And if anybody has seen a movement of ciliated epithelium, it is chilling, because I realized at that moment, if a single cell could survive on its own and in the most harshest environment, nothing available, and survive, then we human beings should have no challenges. We should be able to survive. So I wanted to learn what makes this cell survive despite all challenges, but also such a beautiful orchestrated movement, almost like a dance of a ballet, each cilia moving in perfect unison, was eye-opening. It's that big moment, and of course I was fortunate, because of my passion to read and succeed and learn about the wonders of science. I was given a full scholarship. Actually, I had aced in my undergraduate in 5 subjects unheard in their history of their undergraduate school, Elphinstone College, Bombay University, that the dean called me and gave me a full scholarship to medical school free, which was amazing. Then my journey took a turn when I came to this country like an immigrant, because my oldest brother was born epileptic and my father wanted me to look after him. So I also did my residency at Mount Sinai School of Medicine, and then I was accepted in most Ivy League schools, but I opted to stay at Sinai because I sort of I felt it in gratitude to them. My first journey, I had cloned the first gene at Mount Sinai, which was the epidermal growth factor gene, before the molecular science labs were set up. And I had to work with individuals who had a rough journey themselves as biochemists. Then when I went into after residency, I realized firsthand differential care being given to uninsured, undocumented and all, while there's preferential care being given to insured individuals. And I found more and more populations that had this type of care, etc. So I applied to Mailman School of Public Health, and they wanted me to write an essay why I want to do public health. And I wrote, and they took 13 students out of this whole country, and I was lucky to get into that school. And that's where I learned about the healthcare system in the United States and how difficult it is to navigate. So I was thinking, here I am, relatively healthy. Lord help those who fall sick. Who's going to help them? So Downstate was lucky for me that they gave me the opportunity to come here. I've been here since 2008, and it's being given an opportunity and support is very essential, and I got that. So I thank you. That's been my journey.
That's amazing. Thank you. Thank you. I'm not sure if the audience online as well as the audience here can tell, there's a thread here. A single voice can yield the most beautiful change, whether it's mentorship, whether it's our families, whether it's the individuals that we want to serve, that yields what we love to do, and that's creating health and promoting wellness. And that leads to our second question, and I'll start with Robert, Dr. Wong. When it comes to equity and institutional change, we know that now more than ever, equity is not the same thing as equality. These are two very different concepts, two very misunderstood terms. When it comes to institutional change, we often think macro, but maybe we should think micro. And I think our conversations today will yield a little bit more of the micro changes that will hopefully lead to the macro results. So starting with Robert, what health disparities within AAPI communities do you focus on specifically or would like to focus on?
Oh, I'm a neuroscientist, so my focus is in brain function and disorder. So I focus on mental health, and especially I have an interest in following the diversity within the AAPI community. So interestingly, conditions like autism and depression are usually underdiagnosed in the AAPI community because of stigma and also cultural barrier that sometimes prevent family members from seeking help. So I'm interested in how these kind of background develop. And in particular, I'm also interested in as I mentioned, the diversity within the AAPI community. So in terms of diversity, a good example would be on the surface, Asian Americans has the lowest suicidal rate. And that's a study by Anthony Bai in Washington University of Washington, in Seattle. However, he looks deeper into it and found that among the AAPI community, the Vietnamese, the Japanese American, the Pakistani American, and the Thai and Cambodian Asian Americans has actually the highest rate of suicidal rate. So I think the information that I get from these kind of disparity would be that it is important to recognize the individual communities within the AAPI group, so that the attention can be paid to target areas of problem. Otherwise, if it were all covered by the general realization that, AAPI groups don't have any kind of suicidal problem, then we'll miss the opportunity to target our therapeutic approach to address a problem at its crux.
Thank you, Dr. Wong. I think that's very powerful in regards and hopefully kind of debunking the monolith of the AAPI communities. Ranjita, if you don't mind, I would love for you to speak on your experiences at the front line of seeing that it's not just one category of issues when it comes to AAPI. So your response to the question, please.
Yeah, no, for sure. I mean, I think that just getting to see the different people in the different communities, the microcosms of those little, they're not all the same, is really helpful. And kind of on the same vein, like we learn all these things in medical school. There's lots of decision rules, which of course you can't hang your hat on a specific decision rule. But, for instance, like the heart score, if you use a heart score, but when I was in residency in Elmhurst, like Bengali patients had really high risk of having heart attacks really young. So we'd have 25-year-olds who said they had chest pain. And if you just went by some of these decision rules, you would discount that, right? And so we are not always taught so much about all these little things that are different between these different cultures. And, and other people, like some cultures are very they're stoic and they don't, want to show their pain. They don't want to they don't want to bother anyone, and you need to take them seriously, even if they're minimizing things. And then there are I've seen the other end of the spectrum, which is that there are some people and some cultures that feel as if they are very easily dismissed and they're unseen. So unless they make a big show of their symptoms, they're not going to be taken seriously. And people have a tendency to be like, oh, they're overreacting and they're probably just fine, And so I think that's why I've really enjoyed getting to work with so many different populations in different places, to have that understanding of how different each of these little cultures, both within the AAPI and generally, are. And a lot of the work I want to do is also just elevating those underrepresented voices and in medicine or in the community, so that more of us can learn, so we can't all go everywhere. So that's been a lot of my focus.
Thank you, Regina. I think that also speaks to Downstate's value of not being a cookie-cutter approach to healthcare. I mean, we have some of the most complex populations to serve. In many respects, cultural humility is not something we gain. It's something we work towards. And again, none of us are competent, but we're trying to get towards competency and achieving competency, which, by the way, is not possible. But that's a good thing, because we're learning something new every single day. Jennifer, and then I'll go to Dr. Sagi as well. Jennifer, any thoughts on this, especially when it comes to the correlation between Afro-Caribbean or West Indian populations as well?
Yes. I mean, I think that there are a lot of, difficulties that minority populations, AAPI communities and Afro-Caribbean communities face in terms of healthcare disparities. I think that one of the main ones that I do see in my day-to-day practice is glaucoma. So glaucoma affects many, a large portion of the Afro-Caribbean population because of the genetic predisposition. And the thing about glaucoma is that, a lot of the times people do not know that they have glaucoma until it's in the late stages, because it's asymptomatic initially. But then when it gets more advanced, you start having vision loss, especially peripheral vision loss for the most common types of glaucoma. With AAPI communities, glaucoma is also, prevalent. They do tend to get a different type of glaucoma. Narrow angle glaucoma is more common in the Asian population, but the Asians can also get the, open angle glaucoma. That is the most common type of glaucoma. So I think that, these two populations do have to, get more access to healthcare and healthcare screenings, and also to gain more education about, the nature of diseases like glaucoma, in which you might not be symptomatic until it's in the late stages. And the thing about glaucoma that's very dangerous is that once the disease is advanced, there's no going back. It's irreversible. So it's critical to catch people in the early stages to prevent permanent blindness.
Thank you, Jennifer. Yeah, I think this opens up Dr. Sagi as well in terms of talking about the differences in regards to accessing care, but also where does institutional change start? Does it start at the provider level? Does it start at the policy level? Or does it start much higher? Dr. Sagi, any thoughts?
Yes, thank you. That's an excellent question for me. So I truly believe it starts policy set by providers who have the vast experience, as well as who have dealt with these situations firsthand, dealing with this differential outcomes, seeing, for example, being dialysis. I'm a nephrologist. Chronic kidney disease is rampant. In fact, it's becoming like the second or third leading cause of chronic diseases because of diabetes and obesity. But clearly, if you go from one dialysis center to another, you see them congested with more African-American population, Afro-Caribbean population. And so it was not known for a long time that actually many of the African-American populations carry a gene variation in APOL1 gene, as an example. There was a biological basis. It's not that because they were of differential race, color, or so, but there was a biological basis. And, so at SUNY Downstate, I started one of the first trials with FSGS and African Americans with APOL1 predisposition to see if we can stop the disease and halt it and prevent the kidneys from failing. That's just one example. I also started the next program. It used to be felt that polycystic kidney disease is only in Caucasians and all. If you go around, they were getting all the cares. But here I was in my clinic seeing, lo and behold, such gigantic cystic abnormalities in African American, never described before. And so I studied the genetic. Of course, I wanted to rule out a biological basis before I address access to care, right? So it turns out, there may be differential genetic expression in some communities, especially in gender and age-based, that's where that's the direction I was going, in which the role of estrogens plays a big role. So whether you're African American or Pacific Islander, it doesn't matter. It is more gender-based rather than, which race you belong to, right? So, I also started sort of a bank to do ancestry mapping on some of these individuals in order to really exclude biological basis before I started addressing access to care, right? So yes, Columbia did teach me how to address access to care, and we had good economists. But the problem, and I must mention this with the current political environment, it's going to become more and more difficult as we head into this in trying to challenge, access to care, because access to care, I still believe, should be universal. That removes the barrier very easily. But yes, so I think it's going to be addressing, biological basis, and our basis in order to provide care to them. But one has to be sensitive to the needs and listen to the story. That's the key, as a provider, before they set policy. Because what should trigger a policy write-up is that something really bothered you, and then you go about changing it and seek the help. Operationally at Downstate, they're very helpful to make things happen, which I'm very happy about. So thank you for that question.
Thank you, Dr. Sagi. Yeah, I think you're absolutely right. Active listening is not something we're born with. It's something we have to kind of hone in on, especially as professionals. I mean, if we just listen first, way beyond the chief complaint, we might figure out what's going on in many cases, and inevitably save time, save resources. And Tina, I think I would love to hear your perspective as well on the question, especially from a policy perspective.
Absolutely. And just to tie all the comments that have been made already, which is to talk about the interplay of what happens in the exam room and then what happens in the outside world, right? Outside of the hospital, outside of the walls of the clinic. And there were several comments that alluded to this, which is, health disparities is what we see as a result of inequities, and the impact to social determinants of health. At New York State Department of Health, we believe that everyone should have a fair and just opportunity to be healthy and to be well and to achieve that optimal health, regardless of who you are, where you live, where you come from, anything, right? And so when you think about that, what is discussed in the exam room? Okay, so the patient needs to have a healthy diet. They need access to healthy foods. But what happens to that individual when they go outside the four walls? They need to prioritize paying the bills. They are prioritizing other things. And it's not because they don't want to prioritize healthy foods. But there are so many different factors that impact individual choice. And at the end of the day, I think we really need to really better understand social determinants and how nuanced and complex they are and how much they play into the day-to-day decisions that are made by individuals, and also what that contributes in terms of outcomes. You talked about the very important distinction between equity and equality. They are certainly not the same thing, right? Just because we give two people the same things, will we see the same exact results? Not necessarily. Impossible, right? This individual may need a little bit more, maybe something a little bit different than this person. But how do we think about that from a policy and institutional perspective? It is It is complicated and it is nuanced, but it is not impossible. So I do believe that there are great things underway to try and understand those nuances and make sure that policies and systems reflect those complexities. But we are not quite there yet. So what we focus on in terms of health disparities, we have a number of public health programs and services that are covered by the New York State Department of Health, Public Health. And we focus on a wide variety. But for my office, the Office of Health Equity and Human Rights, what we are really focused on is really naming and talking about health equity and making sure that that is a foundation of everything that we're doing. So whether you are responsible for reviewing contracts or whether you are responsible for administering, technical assistance to healthcare providers, how are we embedding and thinking about equity through each of those approaches? We are focusing a lot on health equity competence, in addition to that cultural competence and humility, and also really thinking about how do we better name and start to identify some of those improvements in like policies and procedures and systems changes. So better integrating that lens through our day-to-day work to then inform bigger policy and systems changes that really can reflect some of those nuances. That's what we've been focused on.
That's a lot of golden nuggets there, Tina. More or less. I think that's very powerful as well. What's practical may not be priority. That's very, very interesting, very deep, folks. If you think about it, our textbooks were read as the golden truth. What we learn in terms of webinars and modules and online learning, is that really practical in terms of implementation? Is active listening difficult? It is. It requires work. It's not just easy as just to say it is. I mean, this goes to our next topic, and Tina will start us off in regards to barriers, bias, and representation. I often tell my students that barriers are good things. They allow us to pivot. Barriers are not red lights. They're technically stop signs. We might have to slow down, but we have time to think, time to maneuver, time to strategize. Biases are all around us, and they don't necessarily have to be a negative thing. Implicit biases and explicit biases, as Ranjita stated, are powerful tools of reflection. And most importantly here, representation. It's not a race. It's a seat at the table, but first acknowledging that there's even a table to begin with. And this goes into our third question. Have you encountered invisible minority dynamics in leadership or diversity, equity, and inclusion spaces? Tina, will have you start off?
Absolutely. So for me, I feel that in my career, it's been very important to focus on individual and group buy-in. And when I say that, there are a lot of people nowadays who will say, oh, I totally believe in health equity. I understand what it is. But when you kind of go into the details and you ask some specifics of okay, what exactly informed this decision, or why are you recommending this approach, or why is work done in a particular way? I am working in an institution that has been around since 1901, providing for public health and healthcare services in New York for a very, very long time. And so there's a certain way that things have been done. And so when you come into this space and you're like, wait a minute, why are we doing it this way? It causes a moment of inflection. And I feel that buy-in is important, and as well as openness to learning and growing. There are a lot of people around me who own their biases, who name it, who identify it, are actively working on it. And for me, you don't have to be at the end of the road. If you're working on it with me, then we're gonna get somewhere. But it's the people that I encounter where they don't take that moment and they don't understand what we might be inadvertently perpetuating by not questioning, by not closely re-examining. Oh, that's just the way that we've done it, And I think, and so for me, that's been very interesting. And I think the other thing that's been very powerful in terms of overcoming some of these dynamics, especially in leadership, is the power of the voice in terms of lived experience. We want to make sure that the very groups and the individuals who are making key decisions that impact public health and healthcare for New Yorkers are the people who look like me, who have had experiences like me, and can speak to the solutions that may help individuals like me. And so we're talking about institutionalized. How do we typically think about education and who we put traditionally in leadership positions, and really thinking about talents and skills and experience and elevating that, where it's not just about the credentials at the end of my name, but it's what communities do I live in? How do I bring the trust and the rapport from those communities and inform and bring power into the decisions that are being discussed? Those things are less valued. And you can see it, right? Like if you pull up a job listing, the first thing that comes up is, what is your educational, credentials? And we know that there's a long history of how racism, classism, sexism have been institutionalized even in our very education systems. So the people who are accessing and able to get those credentials, who then are in these spaces where they can create leadership decisions, we have to kind of turn that upside the head and think, okay, well, what other things should we value and bring to the table? And so that's what we're really focused on when we're talking about diversity, equity, and inclusion. And I will stop shortly, which is I think we need to talk about the elephant in the room, which is what is happening in our federal climate with the discussion on diversity, equity, and inclusion. Diversity is being framed as a bad thing. There's no other way to say that diversity is the power that informs the richness of this country. But there are some in Washington, D.C., who feel that diversity, equity, and inclusion means that we're doing something unlawful, that there might be some discrimination. And really, diversity, equity, and inclusion was to proactively and intentionally address some of the institutionalized and systematized ways that we are bringing certain voices to the table, And so I think that we're really at a pivotal moment in history where we, as a culture, are finally coming around to this place where there is more acceptance and discussion about diversity, equity, and inclusion. And right at this point, we're getting a foot down. And so I think that's where we really need to think about how do we continue to strengthen our the ways that we are doing this work, and also not go quiet. There is a lot of blatant extortion happening with institutions, with organizations, with corporations. And I think that's where all of the work that we're doing in terms of from the clinician level all the way up to institutional, all of those things that we should continue to pursue, because we need to make sure that we have data, that everything that we work off of is evidence-based, that is science-based, and ultimately that it's reflective of us, which is very much about what Downstate is about in terms of creating a system and a community where we are representing the communities that we are serving. So that's...
My students taught me a term, and this term popped up when Tina was speaking. It's positive disruption. Sounds aggressive, I know, but it also sounds like it's action-based, and it's based on data-driven decision-making. A term that I've heard a lot from Dr. Alan Lewis at the School of Health Professions. It's kind of being more objective with our actions, leading to measurable variables and measurable outcomes and change. Again, it's an important factor here in many respects. There's a lot to talk about. This conversation is getting very heated. I'm getting very excited. I think we're going to get into the actual more of the meat in terms of looking at the real issues affecting multiple communities. but also who are the change makers in these conversations. So I'll go to Jennifer. Any thoughts on Tina, or just your thoughts in regards to representation, bias, and barriers?
Tina, you're so eloquent. That was really well said. And I think that that's a really important topic that you talked about. In terms of, bias, I can talk more from a personal level, less so from a policy level that I have less experience with. But on a personal level, yes, I do experience, bias, not infrequently. A lot of the times, because of how I look. When people see me, they don't think of, a surgeon or, a doctor immediately. And just a, quick anecdote about something that happened to me recently. I had a patient in my office who had a really, really dense cataract. He was only seeing movement out of that eye. And I had met this patient at least 4 or 5 times. And I did his cataract surgery. He went from hand motion to 20/20. He's very happy. At the 6th visit or something like that, he wanted to do the other eye, which also had a cataract, but not as severe. And he asked me, so who's the surgeon? Even though I had met him 6 times before, and I always introduce myself as Dr. Park whenever I meet patients. And after or at the beginning of each visit, I also say, hi, it's Dr. Park. How have you been? So I think that, that's not an isolated example. Things like that happen to me often. And, even when I'm in the hospital, I'm frequently mistaken as a nurse because of the way I look. So I think that diversity in medicine is really important in terms of having, different types of people treating patients and, breaking those stereotypes that are still very pervasive.
Thank you. Thank you. The frequency of bias is inexcusable. It doesn't really matter in regards to frequency. It still happens. Shouldn't happen, but it happens. And again, we often take frequency as a measure of it's not a big deal. It doesn't hurt me or it doesn't hurt the work that I do, but it does. It doesn't have to be visible. It can be invisible. Just like in many cases, mental health and wellness is often an invisible diagnosis or an invisible process. Ranjita, any thoughts from your experiences in the ER or just in general as well?
Yeah, of course. I mean, I definitely relate to a lot that you're talking about. And I think in the same vein, it is tiring, I'll say, especially as a physician who works with patients who usually don't know you. And so over and over again, I feel more that I have to establish my credibility, especially because I know I look very young. And, people told me that. And then, so I feel like it's great, the patients like me, but I talk a lot more because I feel like I can't just say, oh, you have a cough, you can go home. I've seen some of my older colleagues be able to do, but I really feel like I have to explain out what I've thought about, what I've looked at. And, it adds up, and so it's just been part of my practice, but I was just reflecting on it, that's tiring. And I think it helps when people, both colleagues and the consulting people and the patients can see different, what you can look like as a physician or other, there's not one thing that you think of. And it's kind of like you were saying, that it's, it's nice when people are trying to address their biases, right? But if you're not, exposed to a diversity of people, how would you even know you have a bias, right? Working with some of the, I worked with MSF and worked with some providers in low resource areas. And I think there's also, I don't think I realize this, but I think a lot of people, I saw some other people had some biases that if you're in a low resource area, that you may not have the same medical knowledge as someone in a higher resource area. And that is possibly completely the opposite, and so you may not even realize that you have that subconscious, but unless you are exposed to these different opinions and people, you're really not going to be able to push yourself. I mean, I think that's why I know that, I don't know if we're talking later, but in terms of mentorship, I've had amazing mentorship, But I also think that it's really nice. I think we get drawn to people who are kind of like us, or further along in the career, but like us. And actually, I think having mentorship that are of people completely different is going to be helpful on both ends, because, like I have a very close friend who's, a tall white man, and his main mentors were these other tall white men. And it was great but he runs a really big program, kind of a peer-to-peer program for one of the big health systems. And they were picking people to be part of this program, like becoming leaders, just based off of vibe, like lots of people wanted it, lots of people working, and nobody in that leadership circle seemed to see the issue with it. Like I was like, you just think this person is going to be good at this job. I mean, that is just wrought with issues of picking. You're just going to pick people like you. Like you've just selected a bunch of other tall white people so far because there's no standardized, like thing to look at their credentials. Like you don't know what people can offer. So, I think that it's, I don't know. I kind of feel like I got off a tangent on that, but yeah.
No, you're fine. We're gonna let you cook. Yeah, just go ahead. Yeah, no, I think we should, just for the sake of time, I think we're gonna move forward. But Ranjit, I think a lot of terms that came up to all of us, I'm sure, were the idea that biases create burnout. Burnout is something that's not cured with a pill. Burnout is something that requires reflection, and in many cases, burnout can be caused by not only just provider to provider, consumer to provider interactions, but institutional gaps. Inequity, institutional gaps in policies, institutional gaps in protecting their own. We'll move forward to Dr. Wong and Dr. Sagi as well, and then we'll go to the last question.
Thank you. So on the topic of minority dynamics in leadership, diversity, equity, and inclusion, I'll first focus on a little bit of diversity as in differences between cultures, and then maybe go into inclusion, and finally equity. So by diversity, what I noticed is that I've seen cultural mismatch and language barrier can subtly but powerfully affect leadership selection. Let me define what it is. Is that the traits often defined in this country as leadership quality consists of assertiveness and self-promotion. Now, they don't always align with the quieter and more cooperative approach in many of the Asian countries. So because of that, because of the mismatch in the traits that's considered important to be in a leader position, AAPI community is often bypassed, and there's no chance to test their absolute capability. So recognizing that is important, and to actively address this is also important. So that's the diversity. So what about inclusion? I think inclusion goes both ways. As a Chinese American, it is my job to adopt what is the strength in this country. There's no question American is a powerful capitalistic country, successful. So it's for me to look into the existing system and see how my value can contribute to build up a stronger approach. In fact, in the Silicon Valley, there's a development that as a group of working together, the leader is the guy that has the best idea, and that's for example is incorporation of a more cooperative approach. Now, I'm not saying that therefore in this case this approach is better than the other, but I'm pointing to the strength of America is that it's an immigrant country. And its ability to absorb what is excellent that brought about by different culture. And I think that it is upon me as a as a person, Chinese person, to see what is good here and bring on to what I think we may or may not be do better. And it is an objective process. If what I introduce is good, I'm sure that America so far has been a merit-based country. It will be incorporated. So that's inclusion. And what about equity? Now, with the inclusion, the recognition of excellence that you can bring to the table, then equity is a natural conclusion. It's not a forced process. If the system can actually recognize the strength of different components, like America is doing. I mean, most of the high-tech company chiefs are foreign-born. They can utilize diversity and strengthen in front of our eyes. So the equity aspect is a natural, can be a natural process that after people realize that this is the best way to go.
Thank you, Dr. Wong. Dr. Sagi?
Thank you again. After I heard the voices, Tina's discussion and other panels, yes, so, rather than, first of all, I just want to make clear biases will exist no matter what we try. Yes, we can be activists, we can try our level best to remove implicit and, external biases, but they will exist. So, and it is very tiring to constantly fight those battles. So what the pathway I have chosen instead, in order to bridge all of this and to sort of bring in inclusivity, equity, etc., is to first address us being transparent. So transparency and for the world to know that these exist is very important. If we don't write about it, if we don't publish about it, we don't discuss about it, we'll never cross this barrier, right? So very often, many of these issues are not transparent, and being in a closed room with a patient, they become transparent all of a sudden. For example, stage renal disease, when it was further fragmented into which communities, it seems like Bangladeshis have the highest rate of CKD progression to ESRD. They have completely uncontrolled sugars. And so, I'm just giving an example. And until that it is published to show, listen, there's a critical need in that community to be educated what nutrition should be given, how they should devise the culturally sensitive nutritious food, you're never going to get rid of diabetes. You're never going to get rid of hypertension. Forget it. You can throw in 20 pills. It'll be useless. So yes, first of all, I believe transparency in publication so that everybody knows. By the way, there are 10,000 articles published every day. Did you all know that? I just learned that just yesterday in attending one of the seminars, which comes to about more than 3 or 4 million articles published every year. So there's no human being can keep up with this. So we need AI to integrate all of this and help us address and identify where this information is being published and what is being written about it. My other thing is finding common themes. That's the word I like to use. We will always be fighting. There will be infighting. There'll always be struggles. This is never going to be corrected over. So what do I mean by finding common themes? I don't know if you all know, ACGME just put out that they're going to remove diversity, inclusivity, equity from the requirement from all programs because they are scared of the political environment. They made that decision, which is crazy because we enrich, we don't hurt. I mean, we bring in different themes, different views, we help grow. If they're going to remove that as a requirement, all the effort we put in has gone down the tubes, right? So it is a scary time. But so common themes is what I wanted to mention quickly about. Is like when we speak to different cultures, for example, what are the common themes? What is food? Food is common to all. It's a requirement. So how can we bridge these gaps is what I'm always looking for rather than finding, there's diversity, there's gaps and all. We're biased. So they're very hard to cross. So those are the two themes I stick on. Are we being transparent about this? And two, can we find common themes to bridge this and find solutions? So that's all I'll say.
Thank you, Dr. Sagi. I think you touched upon a lot of our questions, and I'll move towards closing reflections in a quick second. But, the things about transparency, research, publication, scholarship, again, not as a quick, not as a corny pun, but at SUNY Downstate, we have an immense number of students from the College of Medicine, College of Nursing, School of Public Health, Graduate Studies, School of Health Professions that represent, in many cases, those that we serve. This is one of the most diverse playing grounds of knowledge, of intellect, of research, way more, with all due respects, way more than our counterparts in Suffolk County or way more than our counterparts in upstate New York. We face many more challenges here educating the future healthcare practitioners than they do in other more rural areas, and with all due respects. And I say with all due respects because I'm a part of the UFS, so one of my colleagues in the faculty senate can hear me from now. We have challenges that are not mimicable in other areas of New York State. And again, when it comes to publications and research, we are a heavy training but heavy teaching facility at Downstate. And this comes to the closing reflections about a lot of the concepts we heard today about breaking the monolith, that Asian Americans doesn't exist. Asia is a continent. There are many cultures, many ethnicities in Asia. Who are we talking about? Are we talking about Indians, Japanese, Koreans, Filipinos? What languages are you speaking about? The interpreter on the phone, do they really understand the nuance of tone? Do they understand pain? Do they understand dialect? Do they understand empathy that you can't mimic over an interpretation that's not humanistic? So again, to Dr. Sagi's point as well, AI is a huge contributor, a huge asset that we can actively leverage when it comes to hopefully closing a gap in those healthcare practices. So closing reflections. What is a myth or misconception about AAPI communities do you wish to debunk or to just let loose in terms of having a conversation and also kind of entertaining a challenge to have more conversations around? Robert, we'll start with you. Just, and again, a misconception about AAPI communities. Dr. Wong?
So it's relevant to the research or the initiative to advance underrepresented voice. And I found that one of the most meaningful way to raise underrepresented voice is with honest mentorship. I may not have a formal program or initiative, but I promise myself to provide truthful personal experience and share with peers and younger colleagues. I share with people about my life experience, about my success and failure, and the being told about the what works and what doesn't work. Others may have a takeaway about maybe a reference as to navigate their own career, and maybe even empowered by the fact that certain things are possible. And also, when others hear that the challenges and overcoming challenges by others, they may empower them. So I believe that peer-to-peer support is one of the best ways to elevate voices that need to be heard.
Thank you, Dr. Wong. Ranjita?
Yeah, I completely agree with that. And, I think that what I've also found is that a lot of minority groups or, people that don't have the connections, like they don't even really know how to elevate their own voice and get those opportunities, or they're not able to because they're taking care of like their family, or they don't have the resources. And so, I've really been wanting to use my abilities to be able to have those people. They have so much to offer, and these to give them opportunities to speak or maybe do some, like speaking at our resident conferences, for instance, or vice versa, and being able to connect people to the kinds of mentorship and connections, which honestly, no matter what, that makes a big deal. Like it makes a big difference. So I've found that has been very helpful because it, that's like what we really need for them. So, yeah.
Thank you. And we'll end with Jennifer in regard to time.
I think that an important topic that I want to, keep talking about regarding AAPI communities is the importance of seeing, these community members in more leadership roles. For instance, in medicine, there are a lot of Asian Americans in medicine and healthcare, but in terms of when you look at the leadership roles in healthcare, Asians are highly underrepresented. And for me, during my education and, my residency fellowship, I was fortunate enough to have, leaders that did look like me. When I was in residency at New York Pioneer, James Tsai was the chair there. He's Chinese American. And when I was at Illinois Ioneer Infirmary in Chicago, the chair there, right now is also Chinese American, Dr. Chan. And my fellowship director was Elmer Tu, also another Chinese American. So I think that seeing, these individuals in leadership roles really did influence me and, prove to me that, hey, I can do that one day as well. And I think that just goes to show that seeing people who look like you in these type of leadership roles is really important.
Thank you, Jennifer. Seeing, feeling connected, feeling heard are powerful necessities for any successful healthcare institution and ultimately the communities that they serve. I know there's a ton of questions that we have online as well as from the invited guest here. So I'll go to Ms. Walker in regards to questions.
Well, I'm going to take a point of personal privilege here. I wanted to say, if there's a comment really about what Tina talked about in terms of people owning the biases. I think that's a critical conversation, particularly now and what's happening as we face the challenges we're facing from a new administration. And I feel very comforted knowing that there are people like you all who are also the next generation of leaders in the AAPI community and the medical community, the research community, scholarly community, but you're talking about the things that are critical. It is not something that we shouldn't inspire others about. It's important to have that conversation and not go quietly. So I wanted to commend you on what you talked about earlier along those lines. And I think it's critical to hear voices like yours and all of our folks here to really impact where we're going to go next. So if we don't continue speaking up, we're not going to be able to bring that next generation of our leaders across the board. And it's not just people who look like you or people like me, women, men, it's everyone. We have to bring everybody along. And I'm really very heartened at the commitment that I hear from you all. So thank you for that. In the meantime, thank you. Hey, Chris. There are a couple of questions I'd like to come over to you, sir. Do you mind?
No, I don't need the mic.
Oh, well, actually, it does help.
No.
If you can identify yourself.
Yeah, I'm Dr. Dalul, the interim chair for OBGYN. I really greatly appreciate that. But during the discussion, which is extremely high quality, everybody will agree about that. I remember during the activism period in the near 2000 era, and another colleague from New York State running another department in this state, and where in that year, I did over 10 grand round presentation for social determinant of health and other activity and DAI. And he told me, we never care about that in our institution. There is nothing exists about this in our institution. So when I come here to hear it 10 times that year, and I look at the landscape and there's other people, they don't know about it. They don't know about the selection bias or resident distribution that we have to answer every year, what they belong, where they coming from. All this does not exist. Then we live now in an era that everybody talking about policy. So I'm just going to throw quick words, policy, but this can be eliminated in one race of pencil and then it become a new policy. So how we can spread a thought of and culture of a humanism rather than just spreading policy that can be erased with changing a person and who's running the policy. And in China, just because there is a representation, a very famous talk that they have one party, but they have changed the policy every day. While in America, we have two parties, but we don't change the policy. I really don't know where you stand with that. And in the peak of our talking about diversity inclusion, it is very dangerous term come up, which is the long-termism that now is flourishing out, and everybody try to talk about it and belong to it so they can feel empowered, while we are here talking to ourselves, which is all of us basically in the same side. So how much I have to convince my family that we are more humans in order just to converse our neighborhood or go to much wider space of population rather than just stick to SUNY Downstate. But there is other place in the world that maybe they still don't recognize that dimension. We are so much behind, and I think humanism in the 21st century, it is really, we are going backward in some certain, because with the media and plus all idea that exists in the world, we feel we are very short, very, very, very short-handed. And I think humanism is set back. We are 2025 now, right? It's too long. It's too long time. So I don't know if, and this was raised significantly in the last year or so, how much setback we have. So, and how much we have to go to fight, and who's going to be joining the fight with the spread of fear and caring about your personal life and your personal interests. So it is very, very complex. And I don't think we are close at all. I don't think so. I know we have few million publications now about social justice of health, but that's nothing. Nothing. It is not science. It's more than that. It is more than that. We have to work hard on ourselves as a human, and especially healthcare provider, and with all level, from nurses to anybody work in the system. All of us have some deficiency that we need to fill. Thank you very much, Bana. I appreciate it. Speak.
I'm Dr. Sarah Marshall, and thank you all for a great program. And I definitely heard a lot from each of you, especially when I heard someone speaking to the African American. What came to mind is that this is supposed to be an Asian celebration. So therefore, in your reference to that, number one, how do you then determine if they're African American? That's another topic. And secondly, do we have someone on your panel to really speak to that? Another thing is, I am from a diverse family, and we celebrate Epiphany. And one of the things during those times where you have the different cultures is that they seem to kind of, as one of you mentioned, clink together, like they go to those who are alike, as opposed to integrating with all the group that's there. So if I had to ask one question, I would want to know, how can we then eliminate the separation and deal more to the self, understanding the self-biases, and also being able to make that integration, especially in a world as America where we live?
Okay. Address that both questions, both comments a little bit. Okay, so I think that we here emphasize the importance of recognizing the segregation of groups within AAPI, to recognize that it improves the efficiency of healthcare delivery in some case. But I also want to remind us that we actually has a lot of advantage in being a group. Let me just talk about AAPI first. And under the adage of divided we fall, united we thrive. So in terms of that, for example, there's a policy about no foreign students anymore in the United States of America. And number two is you revoke all the visas for Asian students. That just came up this morning. Not all, but some. And as far as, let me just narrowly focus on AAPI community. I think that I can get support from my AAPI community because of the shared experience. Many of us one generation, two generation away from the immigration experience, and some of us are experiencing the immigration experience. So we have a common ground in recognizing the danger of being excluded. Now, to expand the initial idea that united we stand, I think that it is not to our advantage to be exclusive, but we need to be cohesive in the lowest lying fruit first. And the politics that you talk about in the United States, it's the voice. The more united, the bigger a group there is, the bigger the voice. And it is a democratic process. So I think the key is that we are focusing on AAPI because we need to have our community feel warm. And I indeed feel very warm and welcome by my AAPI brothers and sisters. And it would be extremely fortunate if we can expand the inclusion of a group and find common causes. So the key is to find common causes. And I think that is not difficult for many groups that have shares the similar concern. Inclusion.
Thank you, Dr. Wong. There's one final question from the audience.
Hi, Alicia Goodrich here. I run government community relations. So I feel all the heat of everything you're talking about, dealing with the news of every day. We wake up to something different. I first want to take point of privilege real quick and say, ladies on the panel, I did not think about not just who you are, but then it's ageism, sexism, all of these things that we have to deal with as women, not to exclude the gentlemen. And then when I said, oh, she does look kind of young in my head, I was like, this has to be hard. So we need to have these discussions. Kudos to Dawn and the team and President Riley for us just pushing this narrative. And then I think about all of the conversations that have been happening this year, the symposiums like transport. This is a part of that health equity piece, which is going to lead to my question. But, just know that you're not by yourself, because we share some things. And I understand now being in the community and representing Downstate and knowing that we are in the best place possible. When we walk outside, you meet everyone and then they come inside as well. So thank you for your work. Then my brother, you mentioned positive disruption, which is similar to good trouble that the late John Lewis said. So we are creating that motion. I know it's slow, but at least we're doing it. And it can't stop us from having these events. We'll just call it something else. We have to continue these discussions. And thank goodness we have the ability. Now we have months. And, people get tired of it, but we don't create the space. We're not going to be able to thrive the way we should. So in that spirit, my question is, when you think about health equity, what does it mean to see the whole person? And that's tricky, I will say.
I'll quickly start off. We had a conversation with my students recently about diabetes. Diabetes, whether it's generational, whether it's in terms of genetics, predisposition, or rather if it's something that's based on contextual variables. My students told me that there is no Trader Joe's nearby, there is no Whole Foods nearby. It's cheaper to get a high dextrose, high glucose meal than it is to get something that's much more healthier, much more sustainable. In many cases, I think about what my colleagues have stated in regards to generational experiences. Listening to the whole person is a lot more tedious, but a lot more fruitful than technically just looking at a chief complaint. If it's pain due to peripheral neuropathy, or if it's in issues with vision because of chronic diabetes, you can't change that overnight. It's not about changing attitudes. It's about hopefully kind of planting seeds for different outcomes. If not for your patients, but rather your patients' kin, support cycles, caregivers, and so forth. So I think, again, something we do really well at Downstate is that we don't look just at the simple diagnoses. We look at the more holistic macro perspective of health and wellness. It's not a cookie cutter approach. but it's much more fruitful in terms of outcomes. Anyone else?
I'm not sure if this is exactly answering the question, but also I think as you're exposed to more different people, you can relate to them and create that bond, you recognize that there is more than even the what that baseline thing that you think about that whole thing. You're like, oh, this whole person is still different from the next. Like one Chinese person is not the same as the other Chinese person. And so being able to have, people present like lectures or be friends or colleagues with someone who is different from you, multiple different, races and ethnicities and socioeconomic status, like it helps you recognize that they are not just that one thing, the stereotype, right? So I think that really helps, because then when you see your next patient or you're interviewing someone, you recognize it's not just that surface level stereotype, because you know someone who's very different and has all these levels, which you would think you would do automatically, but I think a lot of times it's hard, right? And so that's why I think it would be great to push for diversity in the what's the word I'm looking for? Mentoring. And I think sometimes that's what I was saying before. It's like you are drawn to some people like you, but actually maybe it's good for some of us as we get higher up in leadership to push for more diverse mentoring between like leadership and below, because you can learn on both ends. Like I've learned so much from people who are very different from me, and it's really helped my practice and my life. And I don't think I was drawn to people very different, or I was intimidated to ask for mentorship from someone who was different from me. So I think those things can kind of help with this as well.
Thank you, everyone. And that concludes our program for today. But before we do, I really want to thank everyone here, Dr. Pagpatan, Miss Kim. I kept calling her Dr. Kim. This is why I paused. She is a doctor in my head. She's on a panel full of people with medical doctorates and doctorates by. So please forgive me, but I see you in that perspective. Dr. Park, I'm going to come back to you last. Dr. Raghavan, I heard wonderful things about her from Dr. Smith. Dr. Wong, you are a legend here. Thank you. And a little more of a point of personal privilege, Dr. Park, I must tell you, was my ophthalmologist. I had double cataract surgery. She took care of me. So please, these are the people that we have at SUNY Downstate. These are the experts. Dr. Sagi has been a phenomenal partner. The Office of Nephrology with the folks led by Dr. Salafu and the folks on your team. We really appreciate you. This community is a community that is really faced with a lot of chronic illnesses, and the folks that we have here at Downstate keep care close in the community. So please make sure that you remind people why we're here. And if we don't have partners like we do in the New York State Department of Health with Ms. Kim, we are nowhere. So I am really very grateful for everyone who's participated in here. So please make sure that you communicate with people. Let's focus on what we do. We don't look for anyone to come in the door and say, treat me because I'm this and treat me because I'm that. They're coming in here because they need help. They're coming in here because they want to learn. We don't look at those things the way that others want us to look at those things and make distinctions about who or who does not belong in this country. We're a nation of immigrants. I'm a proud immigrant. I will carry that wherever I go. So this is who we are at Downstate. So make sure that we keep spreading the word and talking about the importance of why we serve the people that we serve. One other point, it's disappointing and disheartening that we have to have months that are recognizing individuals, like History Month, Women's History Month, AAPI Month. We should not have to do that, but we do because we must, right? And a little bit of a pet peeve for me is the acronym DEI, and this is just me. I use the full words, diversity, equity, and inclusion. I encourage you to do that because DEI has become the negative description for everything that is wrong with what this world wants us to think about. So as you start talking about equity and inclusion, try to use the full words, because then you ask someone, well, what are you really against? Are you against diversity? Are you against equity? Are you against inclusion? What is it that you're against? That stumps them. I will leave you with that. And thank you. Look forward to seeing you at the next one. We're having the Caribbean American Heritage event coming up, I believe, on June 17th. And then we have the Pride Month event coming up on June 26th, I believe. But please keep an eye out. We'd love to have you all join us, whether in person or virtual. So look forward to that. And again, thank you to our panelists. Thank you so much. And thank you, Dr. Pakpatan. Thank you, Dr. Lewis, for that.